So, good afternoon. My name's Michael Stein, and I serve as Dean ad interim, the Boston University School of Public Health. And on behalf of our school, welcome to today's public health conversation. These conversations are meant as spaces where we come together to discuss the ideas and issues that matter most for health. Through a process of conversation guided by expert speakers, we work to build approaches that get us to a healthier world. Thank you to everyone who helped make this conversation possible, including the Dean's Office and our communications team. We are here today to reflect on the current landscape of maternal and child health in the United States. The U.S. has the highest rate of maternal deaths of any high-income nation, a challenge worsened by the racial inequities that too often characterize maternal health in this country. Today we reflect on those challenges as well as on opportunities at this moment to improve our national health outcomes. We are hosting this program in honor of the 30th anniversary of the BUSPH Center of Excellence in Maternal and Child Health, Education, Science, and Practice. Following today's speaking program, we welcome all persons to join the MCH 30th anniversary reception that's taking place in the Talbot building, and we'll get you there if you don't know where that is. And I look forward to learning from our speakers today. But before we get them up there, I would like to take the opportunity, and I have the distinct privilege of introducing the keynote speaker, our Dr. Melissa Gilliam. Dr. Gilliam is Boston University's 11th president. She is a physician and interdisciplinary researcher focused on adolescent health and well-being. She joined the Boston University from the Ohio State University, where she served as executive vice president and provost from 21 to 2023. Dr. Gilliam spent most of her career at the University of Chicago, where she was the Ellen H. Block Distinguished Professor of Health Justice and vice provost. Throughout her career, she has been committed to academic excellence, access and affordability, student success, creating an inclusive culture, and external impact. Dr. Gilliam, thanks for being with us here today.
Thank you so much, Michael. Good afternoon, everyone.
Good afternoon.
Thank you. I am so happy to be with you today. It's just, in the sincerest way, I'm just happy to be with you and be in this company. And I wanted to congratulate you for your 30th anniversary. What an amazing thing, and what an honor. And it's just so exciting to celebrate this with you. This is a place that has been educating MCH practitioners, clinicians, scientists, students for generations. And so congratulations to you and all that you do. Last week I had the opportunity to visit the School of Public Health, and I spoke to a number of you all and your colleagues. And I know that there are a number of concerns that many of you all are experiencing. And so I just wanted to take a moment to acknowledge that. I know that you are worried about your research, about the communities that you impact. And so I really acknowledge that. And I am so sorry that you're feeling these things. But for a moment, let's leave some of those things out of the room, because this is really a critical time. It is a critical time, yes, for us in academia and in organizations, but it's really a critical time for the people that we care about and the people we serve. And so I think these are moments that we have to think with both optimism and tremendous resolve, because this is what you do when you're committed to service. And so today your conversations, and I'm so sorry I will not be able to stay for them, but it's about raising and birthing the next generation. This is an incredibly important topic, but it gives us an opportunity to think about the arc of maternal child health, the arc of women, communities of color, and the history of racial and social disparities in maternal and child health. And this is really a long one. And it's rooted in systems and structures that carry inequality and that go back to quite a long time. When we think about the history of families, Black and brown families, in the 19th century, we know that there is distinct and unethical behavior in the ways that, and I'm an OBGYN, and so how Black women were experimented upon, how segregation in housing and other opportunities have really contributed to the challenges that we are experiencing now. One of the things that was so helpful for me as I left the medical center and came into universities was how precisely we've been able to measure the ways that biases and attitude lead to disparities in health. And so I would say, well, you know, it's not a fiction, right? We know that people get actual differential access to pain medication based on their race and ethnicity. We know that if you come in for cardiac catheterization, the time to which the balloon will be blown up in one of the vessels of your heart will differ based upon your background. And so we have in public health and in medicine the ability to measure the inequalities. And so we are living at a time when we know so much about what causes disparities in maternal child health. And obviously we have a lot more to know, but the concern is that we could roll back. And so as we're starting to think again and think anew about how we take these advances we have in science and medicine and reimagine our relationship with the communities and the policymakers and the people who need to take up these advances, you know, I think that is the critical question. And so I'm really excited that today you'll be having these types of conversations, that you'll be asking about the future of maternal child health. And I encourage you to think broadly and capaciously and to understand at times like this, things that we took as fact, we might have to reimagine and rethink. And so I've also been asked to share some of my own experiences thinking about issues of health and justice. And I actually welcomed that because it gives me an opportunity to talk about how this idea of rethinking the dogma, rethinking the things that you thought you already know as a way of innovating and thinking of moving forward. So my own work has been as an OBGYN. I've focused on adolescent reproductive health. And this has shown me just how important it is to think about not only our own training, but also the communities with which we work, and bringing these communities in as true partners. Now, for me, this has been in adolescent health, and I've worked predominantly with young people. And my work has really been in promoting adolescent health and well-being. And this started about 25 years ago when I was conducting my first ever research study. I was a resident, and it was the early 2000s, and I was starting to look at this body of research, and it was really driven by thinking about the clinical care of Black and brown adolescents. And I just kept seeing one statistic after another. And what it was doing is it would compare Black teenagers, and it would say they're more likely to get pregnant, and they're more likely to get a sexually transmitted infection. They're more likely to smoke. They're more likely to get HIV than white teenagers. In other words, throughout my training, well-intended, I think, but there was this persistent negative narrative about Black sexual health. And parents were so worried that they would bring their children in and say, give them contraception, give them a 3-month shot, put an implant, rather than listen to what their children were saying about their own sexuality and their health. And so as I started to think about where I would focus my research, I decided to focus on Black and brown teenagers who became pregnant within 1 year of giving birth. And if you've ever had a pregnancy, you know within a year is probably not what you desire. So it felt like a pretty an important interval. But what's more important from a maternal child health aspect is that it carries a tremendous amount of risk, preterm delivery, and multiple other challenges for both the mother and the offspring. And so in this study, I wanted to understand whether a high-quality counseling intervention alongside birth control pills, which was the predominant form at the time, could decrease rates of rapid repeat pregnancy for first-time adolescent mothers. And I thought, oh, I've done everything right. I involved young people in the design of the intervention. I held lots of focus groups. I did everything that was considered a best practice at the time. And then off I went to do my study. And so in OBGYN, your postpartum visit, the 6-week postpartum visit is kind of the hallmark. You come back and I'm going to teach you all the things you need to know. And so I was sitting in clinic and it suddenly dawned on me, nobody's actually showing up. And if I had just looked at my clinical list, I would have said, oh, this person canceled, this person, and I wouldn't have noticed. I would have had a full day. But when I was actually tracking the young people, I suddenly realized they hadn't shown up. So I started calling them. And they said, well, Dr. Gilliam, my elevator broke and I'm on the 10th floor and I'd have to climb down 10 floors, or I had a pediatric visit, or I just got kicked out of school because I couldn't get to school on time. And that's actually more important. And so here I had this intervention all about counseling, right? I'm going to really explain how to take birth control pills, but I hadn't actually understood their setting. And so about this time, I had read this article. It was in the New York Times. It was called Separate but Unequal, and it was talking about the segregation in the city of Chicago. And their idea, what they talked about is there are disparities in everything from transportation to childcare or access to banks, access to schools. And right nestled in there was teen pregnancy. And, it was, the light bulb went off. And again, you have to give me some grace because this is early 2000s. And so, I said, oh my gosh, right? These are what we now know as the structural and social determinants of health, but we were designing best practices without taking those into account. And so, and then here I was, I just trained. I spent all this time training in medicine and then going to public health school. And I thought, where is this gap? Trained in this city in medicine, right? So this truly was a good training. And so around that time, I read the work of a psychologist, Vonnie McLeod, and it really stayed with me. And what she said, and I'm quoting, "We do not need to create databases on Black and brown children that parallel non-Latinx white middle-class children. Instead, we need culturally relevant constructs and to systematically document the precursors and developmental outcomes by young people in a culturally sensitive framework." In other words, right, understand people on their own terms, not in comparison to people who've had different opportunities and different life courses. And so really, how do we start to understand people on their own terms? And so I started thinking about a whole new way of conducting research and working with adolescents. And so for that study, or my next study, I left the clinic, got a van, started working directly in communities, sat in living rooms, visited schools, went to community centers, meeting adolescents in their homes, in their living rooms, using their own words. Eventually, I created a center called CI3, and this center is still going, but it was really about thinking about the assets of young people, thinking about positive youth development instead of counseling at young people, but co-designing with young people. I started to ask this question: what if the process of research could leave you with more than it took away? What if doing research was an opportunity to actually build skills in young people? right? Take them and make them part of the project, not the subject of the research. So what we did is we helped them tell their stories through writing, drawing, coding, animation, recording, presenting. We trained them as designers and content creators. We co-created everything from podcasts to graphic novels and digital stories. They spent the summer at the university meeting students and faculty and learning that they belonged in the classroom. In short, too many young people are told what they should not do. Don't smoke, don't drink, don't have sex. These admonitions come from a good place. We want a lot for young people. But what young people really need to know is what they can do. They need to know how they can excel and what special gifts they and only they can bring to the world. And this has been shown to be an effective strategy to prevent smoking, drug use, pregnancy for adolescents regardless of their socioeconomic background, status, country of origin. And so when you help young people build skills and feel their power and ability in the world, then they live healthier lives. And so I like to say that piano lessons prevent teen pregnancy, after-school programs prevent teen pregnancy, being an athlete prevents teen pregnancy, education prevents teen pregnancy. And so we need to help people focus on their strengths and minimize their limitations. So you will recognize this as human capital, which is kind of the combination of health and education and skills that individuals possess that in turn drive innovation and productivity within organizations, cities, and societies. And I use this term from economics because I was at the University of Chicago, so a lot of my collaborators were economists. But I want you to understand that the commitment that we can make to young people is not just because I'm a doctor or an educator or a person of color, but it's actually enlightened self-interest for us as a society, right? Not to waste talent. And if we invest in all young people, then we are not wasting human capital, and we are not losing their contributions to society. And that investment just happens to prevent bad health and is far more cost-effective and far more rewarding than healthcare. So I know a lot about human capital in Black communities from a firsthand basis, and I know a lot about maternal child health from my own experience. So my grandmother, she was, I think, originally from Memphis, and then my mom was raised in Louisville. And my grandmother originally had 10 children, only 5 who lived to adulthood, 1 with Down syndrome. So it really gives you a sense of intergenerational, of generations and maternal child health over generations. My grandmother was born in 1900. My mother was the daughter of a minister and was raised in Louisville. And when she was 12, her father became very, very ill and could no longer lead his church. And so the family moved to a rural area of Kentucky, and that allowed my grandmother to work and care for the family. And essentially, they became a sharecropper. They went to be kind of the first family of the church to essentially sharecropping with a bathroom outside of their house. But the one thing is my mother had a really, really good high school that she was able to go to. My grandfather died when he was 14, and this was devastating because he was so important to her, and she was the apple of his eye, and he really put education first. And so they lived in difficult situations. She went to a great high school, so at 16, she went off to college. And she went to a school that she was one of 5 Black young women in an all-women's college in Kentucky. But at the same time, she started working in the Black Weekly newspaper. And so initially she had a job at the Louisville Defender, and they asked her, even though she was young, to cover stories. And she's covered stories of Black society, and so she went to the Kentucky Derby, and she covered Black businesses, and she started to see how rich and complex the Black community in Kentucky was. And eventually, she would just continue to scaffold that. This is a whole nother story. I'll save it for another day. But she ended up going to school, to journalism school. She ended up at Columbia for journalism, and then became the first Black woman at the reporter at the Washington Post. And so I tell you that story because it shows you why I believe, but I want you to believe, that when you empower a young person, you change that young person, and you change a family, and you change a community, and you change society. So that's what I mean by human capital. That idea of good health and education is why I became a physician and now a university president. And so I became a doctor to help people, and in turn, I learned that the solutions lay outside of the clinic and outside of the hospital and in the lives and experience and wisdom of patients themselves. And now I lead a university because I believe that it is the combination of research and education and clinical care that heals people, heals society, will heal the planet, and will change the world. And so I don't have to tell this audience. Probably I should give this talk to another audience. Invest in people, right? Invest in people. Recognize the power of community and the role of collective action in driving measurable change. Okay, so I'll finish by telling you a little bit about Boston University, where we are. And last week, I was so excited to publicly announce a new presidential initiative to reimagine the partnership between our university and the Boston Medical Health System. So the hospital is actually a separate entity from the university. And we formed a joint executive committee of senior leaders from the medical center and the university to look for new strategies so we can maximize our institution's shared impact. Now, I know this is a really tough time in healthcare and public health and higher education, but we see very real political and societal headwinds challenging us to do the work that we all know matters. But it is more important than ever that all the work we do, that we all work together to do this work, whether it's through research, whether it's through clinical care, or through supporting our communities of students, faculty, and staff, and the people of Boston who rely on us for this care. One of the things that I really like about talking to Dr. Bell, who runs the Boston Medical Center systems, is we talk about the things that happen here, the things that happen in these communities have an outsized influence on the national landscape. People will say, oh, that thing that you're doing is, we're doing this thing. And it's like, yeah, it started here in these communities. And so I know that you all are worried. I know that people are already overworked. I know that people are already tired. And we're asking us to work even harder with even more headwinds. But each of you is such an asset to this community, to the work that you do, to the communities that you serve. So I encourage you to just listen deeply, and I hope that you leave with renewed energy and optimism and determination for the very important work that you do. Thank you so much. Thank you for letting me have some time with you, and I really appreciate it.
That's a great way to start. So thank you, President Gilliam. And I now have the pleasure of introducing Lois McCloskey, Clinical Professor of Community Health Science and Director of the BUSPH Center of Excellence for Maternal and Child Health. And she will introduce our speakers and today's conversation. Lois, over to you.
Thank you, Dean Stein. I must begin by thanking you, President Gilliam. I'm so honored that you took your time, particularly right now, to spend time with us and share your experiences, your insights, your research with us. How inspiring it is and heartening at this moment to know that the person leading, I'm going to tear up, excuse me, the person leading our university gets it in her bones what it is for children and women and mothers and families to flourish without the constraints, with and then without the constraints of racial and social inequities. And to know that the person leading our university is a public health thinker, a systems thinker, a solver, a community engagement committed person. And has led health justice initiatives and been a clinician throughout her career. It is inspiring, heartening, and very, very reassuring. Thank you, thank you. I now thank you, Dean Stein, for hosting this event and your amazing team who has put it together with their usual aplomb. And in honor of the BUSPH MCH Center of Excellence. So, now I want to thank all of you for coming, those of you in person, and of course the many who are online as well. It is really important that we gather together, now more than ever, in person to be together and to remind ourselves of what we know and what we are already doing and will continue to do despite the disruptions that are occurring in our values and in our work. So, let me now begin by introducing our speakers. I'm first going to introduce the Birth Justice panel, 3 people, and they will speak, present one after the other, and then I will introduce the Economic Justice panelists. And this all will end with a moderated conversation with all of them, inviting questions from all of you, both here and online. Starting us off is Nashira Burrell. Nashira is the daughter and the great-granddaughter of midwives with a master's degree in maternal and child health from Boston University, and 20 years of experience designing and implementing public health strategies to advance racial equity. Nashira founded the Neighborhood Birth Center in 2015, 10 years ago, and co-founded the Birth Center Equity in 2020. So as many of you may already know, the Neighborhood Birth Center will be the first of its kind community birth center in Boston, providing full-scope community midwifery to strategically address the maternal health crisis we are in the midst of. Nashira brings structural analysis and embodied practice to all that she does. She has worked at the Boston Public Health Commission, as well as the Harvard T.H. Chan School of Public Health and Human Impact Partners. We're proud to have you join us. Thank you, Nashira. Okay? She'll be here in a moment. But first, I'm going to introduce the next speakers so that they can come up one after the other. Next, we're going to hear from Nidimaka Amuta Arukaga. How'd I do on that, Dee Dee? Not so good, but I'll keep working on it. She is the Julia A. Okoro Professor of Black Maternal Health at Tufts University in the Department of Public Health and Community Medicine at Tufts University. Dr. Amuta Arukaga is the founder and director of the Center for Black Maternal Health and Reproductive Justice and of the Maternal Outcomes of Translational Health Equity Research Lab. She is the founder of the largest conference on Black maternal health in the United States, convened every April. Pretty soon. She received her Master's of Public Health from the George Washington University School of Public Health and her PhD in Public Health from the University of Maryland. In her research, she investigates maternal health disparities, infant mortality, reproductive health, social justice, and HIV, all as it is experienced by Black women. She serves as the inaugural Dean of Diversity, Equity, Inclusion at Tufts University's Public Health and Professional Programs. We'll hear from her. Thank you, Dee Dee. And third, on the Birth Justice panel, we hear from Viveka Prakash Zawisa. Dr. Prakash Zawisa is an experienced physician leader an innovator with a passion for exploring how public policy and systems impact healthcare delivery and social justice. At Mass Health, that is Massachusetts Medicaid, she is our senior medical director and the clinical lead for accountable care and also for maternal health policy. She also helps to lead strategies for member and community engagement at the agency. And Dr. Prakash Suisa is an assistant professor of OBGYN and family and community medicine at UMass Chan Medical School and is another board-certified OBGYN. She also holds a degree in global health policy and still provides clinical services in low-resource settings in this country and internationally. Viveka is passionate about social justice and the tools we have to address health inequities to create an efficient healthcare system that promotes joy and wellness for everybody. Viveka, we look forward to hearing you as well. Now I turn it over to you, Nishira.
Thank you, Lois. Good to be here. I'm going to set myself a timer because I can talk for a long time about this. You all are a sight. Thanks for turning out. I want to start with my own birth story. It was 1979. My mom, a single white mother, gave birth to me in a Connecticut hospital. Denied by nurses to have her best friend present. She had an emotionally traumatic labor and delivery. And when they took me away to the nursery so she could rest, she wept inconsolably, to which they responded by calling for a psych consult. Fast forward 7 years, she opts to have a home birth with my sister. And again, 2 years later, another home birth with my brother. And I, not yet double digits, bear witness to the care of midwives, to my mother's power, and to how home and community have always been vessels for sacred care. I came to BU, I was thinking about this as I walked out of the parking garage, in 2003. So a really long time ago. I was such a baby. And when I got here, I came into community with Boston area public health leaders and midwives, including Dr. Joanna Rory, who's here in the room. And in time, I learned about their decades-long vision for a birth center in Roxbury and how systemic power had been wielded against them, continuing to advantage hospital obstetrics over community midwifery, as it has been since the turn of the century, when midwifery was nearly rendered illegal in many states. Fast forward to 2013, I have my own world-changing, world-shaking, transformative home birth. And as a public health student, a lifelong student, I was driven by how to scale that experience that I had to the population level, right? Because it was a story different than all of my peers, and certainly different than the data that I knew so well. And so I turned to Dr. Rory and other elder midwives, and I said, can we try again? And I offered them my naivete and optimism at their full disposal to test this vision of a community birth center here in Boston. And thus began the next 10-year chapter of trying to open Boston's first birth center. I'm going to talk more about Neighborhood Birth Center, but I first want to ground in the vision for birth justice, which really is a vision for reproductive justice. And I spent time just a week and a half ago at Smith College with Loretta Ross, one of the grandmothers of the reproductive justice movement. And so it feels really important in this, the 30-year anniversary of the coining of that phrase, to really speak it into the room, that reproductive justice is the human right to maintain personal bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. Rooted in that framework, brought to us by those Black feminist leaders 30 years ago, I think birth justice is the autonomy to birth in safe and autonomous ways, and supported both by the ancestral technologies and modern technologies that we have access to. I'm guided by this quote, this Alice Walker quote. She says, how we come into this world, how we are ushered in, met, hopefully embraced upon our arrival, impacts the whole of our time on this earth. I often say, and I think it would be affirmed in this room in particular, that how we birth matters for our public health, for our economy, for our climate, and for our collective well-being. I also have been trained up by social workers, so shout out to the dual degree program, BU School of Social Work. And yes, okay, some dual degree holders in the room. And what I've learned from my social work colleagues is that when we experience trauma, it lives in the body. And also when we experience power, that creates markers, neural pathways, brain wiring that live on in the body. And so I think about how I gave birth in my living room twice, how I have touched a power in me that is so powerful that it shapes the way I walk into a room. It shapes how, I haven't had to show up for an interview in a long time, but if and when I do, it shapes how I show up for an interview, it shapes how I advocate for myself and for my family, and it shapes how I show up for this organization. When we map that transformative experience across a population and across time, I think we are clear that that potential has, that experience has the potential to heal generations. But we need to center our interventions, our design, and build power right where the inequity is, and design interventions at the intersection of all of the systems of oppression, build power there, and in doing so, we build, usher in the future and build, in our case, the birth center, but I think a world that's better for all. And so Neighborhood Birth Center is about reimagining care, that is about remembering and reclaiming midwifery. And we are thinking about how we weave justice into policies, programs, practices, real estate development. And I want to just share a few examples of how we're thinking about that. When it comes to the design of our space, the guiding question that I offered to our architects many years ago at this point is, how do we design a space that feels like it rises up to meet you? A space that interrupts the often impersonal and hierarchical design of healthcare spaces that are set to first meet a receptionist and then a nurse, a PA, and then a nurse, and then a physician if you're lucky. And how do we really create home-like spaces and bring that into practice? We are designing, so what that looks like for us is designing a space with a sanctuary so that people who are experiencing miscarriage or a medical abortion can seek comfort in a quiet space, maybe supported by a chaplain, and exit the building without passing back through a waiting room with pregnant bellies. We have spent hundreds of hours trying to crack the code on what is known in the birth center world as the impossible math. How do we cover our costs while relying on atrociously low and inequitable reimbursement rates from insurance? No shade, Rebecca. She knows what's up. We've talked about this. And how do we do that? How do we build our model at Neighborhood Birth Center while we commit to serving the majority of our client base being mass health, and while paying competitive salaries so that no midwife or nurse or administrator takes a pay cut to leave a Boston healthcare institution or another practice and to serve their community? And how do we do that with reasonable clinical schedules? So that has been the impossible math, and I think that we're pretty close to figuring out how to sustain Neighborhood Birth Center, turning the cost back to commercial and subsidized insurance. And Lois invited me to speak to the challenges, and I was like, how long do I have? And my timer wasn't working that whole time, so I don't know how long I am.
We can get to that.
Okay, I wasn't keeping time. But I do want to speak to the challenges that we faced in realizing this vision, and I want to quote E.B. White, who says, and I'll paraphrase this one, that I rise in the morning torn between a desire to enjoy the world and a desire to improve the world, and that makes it hard to plan the day. And do we feel that these days? Yes. And I feel that every day at Neighborhood Birth Center. I feel like we have one foot in the new paradigm, one foot in the future that we are trying desperately to build, and one foot in the current paradigm. And that means those insurance rates and inequity in pay and inequity in outcomes. And I want to just illustrate a few examples of how some of these challenges have shown up for us. There are very real lived inequities. There's mistrust and trauma from the healthcare system. What it sounds like is people saying that birth is scary and painful. And people have also said to us, I've seen the headlines of this crisis, this Black maternal health crisis. And so if it's bad for Black women to give birth, why would we do it outside of the hospital, right? I have an answer to that, but we have to meet the question, and we have to understand what that's rooted in. I've already talked about the reimbursement rates for midwifery care. One of the other challenges is that we've been relying on goodwill and philanthropy to build this important piece of healthcare infrastructure. And I argue that that's not a good way to build a birth center that really is a part of Boston's healthcare infrastructure. And I don't know if you've caught it in the news lately or you've been following us on social media, but an antiquated zoning code in Boston means that we spent the last 2 years designing and planning and engaging community and amassing the support of hundreds of residents, only to have the zoning board strike down our plans, leaving with us a $2.5 million property in Roxbury that is potentially unusable. This challenge in particular has cost us time and money and a lot of tears. But that brings me to a closing thought, which is speaking to paths forward and opportunities in tough times. So in the face of antiquated state regulations, anyone from DPH here? Shout out to DPH. No, really, I'm gonna shout you out. You don't have to identify yourself until after I give the props. But no, really, so these state regs that we've been crying about and griping about for years, they were gonna cost us time and money and threaten our sustainability. And so we joined a bold coalition of birth justice activists, and in August successfully changed the legislation that holds those regulations. And so that was huge. As a part of that historic omnibus, we also won licensure for certified professional midwives. Any CPMs in the room? No? All right, well still, we'll shout out the CPMs in our communities. This is gonna allow home birth to be covered by insurance soon, and allow the highly skilled community midwives to work in and run birth centers. Duh. And until we secure appropriate contracts that reimburse midwives and birth centers for our care, we are turning to philanthropy, and we've been really successful in doing so, leveraging both government and foundation grants, but also to community in backyard fundraisers. We raised $3 million in our capital campaign with gifts from $5 to $500. And while again, I don't think that's the way to build a birth center, I'm really proud that that's what we did in the moment that we had. Lastly, that, in the face of all of this systemic undervaluing of midwifery, worried whether or not we'd be able to ever break even, we co-created a collective of organizations, all dedicated in different ways to the social justice movement, and we purchased property together. We've spent the last couple years building a model of co-governance and sharing resources, and a model of what I've come to now learn is solidarity economy, beloved economy. And we know that we are more sustainable because we share risk. And that Che Guevara definition of solidarity is sharing risk. And so we call this collective of organizers and midwives and healers and community members the Community Movement Commons. And our multi-purpose real estate project is considered our love letter to the community. It is also a love letter to our ancestors and to our descendants. While we are grieving the ZBA decision, we are also wildly strategizing a plan and path forward. And so this time tomorrow afternoon, those 20 people will be circled up in my living room, breaking bread and trying to figure out what we do with that property in Roxbury. And the last thing I want to say just comes from a place of gratitude that working on opening this birth center in this particular city with those particular regulations and these particular zoning laws is the hardest work that I've ever done. And I am weary. And it feels really good. Lois thanked me for coming, and I was like, no, thank you for having me. It feels really good to be in a room of, at BU, where I cut my teeth in public health 20 years ago, with beloved leaders in the MCH ecosystem, and people who I feel have their hands at my back as the midwives of this work. So thank you very much.
Give it up for Nashira again. That was incredible. Good afternoon, everyone. Really excited. Uh-oh. How are we doing over there? Thank you. Good afternoon, everyone. Really excited to be here. Can someone show me how to work this thing? I did it. All right, here we go. Good afternoon. I would not be an academic if I did not have slides. So thank you to the invitation for Lois. Thank you, Dean Stein. Just really a pleasure to be here with you all today. I was asked to talk about the data and kind of where we are with the system, looking at maternal health and inequities. A little bit about me. Hold on, I'm going to put my glasses on. Thank you, Dr. Olden, for bringing them to me. I'm really proud of the work that I've been able to do at Tufts and with colleagues here at BU. Gene DeClercq has been my trusted co-PI on my grant. Gene is here, Judith. He's my trusted co-PI on my R1 for the past 5 years. And I think a lot of the work that we're doing in the maternal health space is because of what we're seeing in the data. Oops, sorry. Okay. So, as Nashira spoke to, we have done a lot of great work here in the Commonwealth. This landmark legislation that was passed, how many people were at the State House in that day, late August? I was 37 weeks pregnant, belly to the ceiling, getting that legislation signed. It was incredible. And my team was like, okay, I think you're done. I said, are you sure? It was so good. And a lot of the things that we've done here, also thinking about the successes of the Racial Inequities and Maternal Health Commission. Anybody was on that? That was an amazing opportunity as well. Really set the precedent for the work that's happening today. Massachusetts is a leader in maternal health. I think all of you here know that. I think we can kind of rest on those successes, but we also have a lot of work to do, as you've heard from Nashira here in the city of Boston, and what's happening nationally tremendously in a time like this. So the data, I think a lot of people were really excited when the data was first released. Yay, we see a reduction, but it's not really a reduction in maternal mortality. We actually just went back to our baseline data where we were pre-COVID. So we haven't actually moved a lot of the needle. What we have done is return to baseline, so we don't want that spike either. But I think the other part of the conversation when we're talking about maternal health and birthing and raising the next generation, President Gilliam's remarks were so powerful that really just centered me in this moment, but it's to talk about what does it mean to be in this work, and how do we provide messaging and opportunities for different populations? So we know that for Black women in particular, the maternal health crisis is quite large. The disparities are there. When we think about it, when you add the layer of race and age, that makes it even more of a burden. And so we're thinking about infant mortality. I did my dissertation on infant mortality a few years ago. And when I did my dissertation on infant mortality, we still have this twice as likely gap. We have not moved the needle at all on infant mortality. I think we have a lot of opportunities, and I'll talk a little bit in a minute about things that are happening here in the city of Boston and Massachusetts, but this is another area because we know when we improve the health of moms and babies and vice versa, everyone wins. Thinking about the rates here in Boston, as I mentioned, we are doing a great job in Massachusetts, but we also have a lot of disparities. This is the most recent data here in the state and the city. Black women in Massachusetts are almost twice as likely to die during pregnancy or within 1 year postpartum, and when you're thinking about the infant mortality rate, we see disparities there as well. A lot of times when we're talking to funders and philanthropists, they're like, you're in Massachusetts, you guys couldn't possibly have any disparities. I'm like, oh, yes, we do. We have it by zip code, we have it by neighborhood, we have it by ethnicity, we have it by immigration status, language status, insurance status, and the list goes on. So these are some of the things that we're prioritizing here. And the maternal mortality rate as well is also quite high for Black women. So this is, you can't see it because of the podium, but I was 37 weeks pregnant in that picture. So good, she's 6.5 months now. This maternal health momnibus that was passed, I think is incredible. And Shira mentioned a lot of the things that came out of it, and we're still in the process of advocating and pushing for this. I had the privilege to testify last week at the Joint Committee on Public Health, so it's co-convened by the Senate and the House, and they asked me to come and talk about what they should be prioritizing for their next legislative agenda. And we talked about this. Okay, we passed this, now we actually have to do it and put it into practice and make sure that it happens. So that was a tremendous opportunity, and I do think that the committee was quite amenable to the things that we raised. some of the things that we're advocating for, obviously the Maternal Health Omnibus Bill, investing in a diverse maternal health workforce. This is the beauty of this event today, frankly. We're celebrating the 30th anniversary for BUSPH Center of Excellence. This particular opportunity has raised generations of maternal child health practitioners, leaders. We need a more diverse maternal health workforce, right? So how many people are you familiar with the Mother Lab? It was mentioned in my introduction. Yay, motherlab.org. And Mother Lab is my group of students, right? And I started this lab virtually during the pandemic to really garner and support the next generation of maternal child health leaders. And we need more of that, right? We need a diverse maternal health workforce, not only here in the city of Boston, but in the Commonwealth and nationally. Improve maternal health data collection and reporting. This year I mentioned DPH before. I don't know if anybody from DPH is here, but we need, I'm looking at Jean in the back, we sit on the MMRC together. You know, there's a real opportunity that we have in the data collection and reporting as well. So we're collecting the data, how do we churn it back out? How quickly are we able to churn it back out? Working with our partners in insurance, working with our academic partners. That's the beauty of a center like mine that's able to quickly disseminate and translate the data to get it into the hands that it needs to go into. And then supporting full spectrum pregnancy care, right? Making sure that insurance are covering the full spectrum of pregnancy-related care is very important, and it's a battle that we're still in the middle of. All this is happening within the middle of this very, very crazy, unpredictable, stressful, nauseating federal landscape. And I think, you know, in a moment like this, this is the time for optimism, President Gilliam said, but also the time for hope. There's a lot happening that's working really well, and there's a lot that we just don't have the cards for. And what are we gonna do? We're gonna curl up and die? No, that's not what we do. We fight harder. So this quote, I mentioned it in a recent media that I did last month. Well, now we're in April, but you get what I mean. I'm a glass half full person. I do know that even in situations of disruption and situations of crisis, there are good people still working in these places. This opportunity to say this is a moment of a bright spot. And so I think a lot of the work that's happening here is in the landscape of things that are changing, things that are uncertain, but we have to continue to press forward. We are raising and birthing the next generation literally and also in our work. Is that my timer? Okay, quickly. I'll talk about my center. I started it 3 years ago, Center for Black Maternal Health and Reproductive Justice. My team is here. Everybody say hi. Hello, hands up, well. And you know, the center has 6 units. We're really focused on the Mother Lab, as I mentioned, which is my students, a focus on policy, education, development and grants, data and epi, and community engagement. And we're looking to be a catalyst. We're an academic-based center. We're at a medical school, but we're community-facing, community-driven. I would be remiss if I did not mention our conference is coming up this weekend. How many people are registered for our conference, the largest maternal health conference in the country? Thank you. It's coming up, it's virtual, so you can be anywhere. You can be whatever you're doing, you need to do. But it's focused this year on fathers. We've been doing this conference every year since 2018, and we changed the theme. We've done nurses and policymakers and doulas. This year it's on the role of fathers, right? Because they're in the room when things are happening in a pregnancy, labor and delivery. They're watching the hemorrhage, they're watching the mistreatment. President Gilliam talked a lot about that, the biases that occur. The parents and the fathers are right there watching it and feeling like they can't support their partners. So this year is all about fathers. We're bringing a panel of experts from around the country. Some of them have experienced, unfortunately, maternal mortality in their own partners. Our opening and closing keynote both have lost their partners to preventable complications and frankly the racism and bias in the healthcare system. But we have a day full of practitioners, fathers, parents, leaders, so please join us. And then just a little bit about our previous conferences. Last year we did the role of technology, and then the year before that we did the role of nurses and midwives. And then this is my Mother Lab, as I mentioned. The Mother Lab is quite unique. Some of your students here at BU are in the Mother Lab. And you know, we focus on creating the next generation of maternal health scholar activists. How do we create spaces for leadership, for development, for mentorship with students that are going into public health, nursing, social work, anthropology, et cetera. And they're really focused on the skills that they're learning while publishing, creating and supporting doula initiatives and focusing on our role in the community. I'm just going to leave you with this quote because I think I'm at time already, but to reduce the overwhelming gaps between Black birthing people and their counterparts, reproductive justice initiatives values the voices of communities and Black birthing people, to hold stakeholders accountable and to commit to anti-racist approaches that deconstruct foundationally racist beliefs and practices. This is the whole premise of this event today. This is why we're celebrating the work of the BU Center of Excellence in Maternal and Child Health, the work of my center. The work that we're all doing in a maternal and child health space is to foundationally deconstruct these racist beliefs and practices. The system is broken. Sometimes I say the system is broken and needs to be rebuilt. And then sometimes I'm like, the system is functioning exactly how it was designed to function. Unfortunately, right? If any of you guys have seen my TED Talk, which I did, I was like 6 weeks postpartum with my second child. I don't know why I did TED Talk at that point, because it's all verbatim, not a teleprompter to be found. It's all from your brain. And I talk about this in my TED Talk, how broken the healthcare system is. But it's actually not broken. It's actually functioning exactly how it was designed to do. But we are the chosen ones, right? If not now, if not us, then who? And if not now, then when? I always use this quote. If you've been to my office downtown, we have it in our living room. That's where we kind of sit and have our meetings. That's our living room. And we have it on the wall there, and it says, if not us, then who? Who is coming to support the next generation, to help raise and birth the next generation of leaders? We are. Neighborhood Birth Center is. Relationships with health insurance is. Academia is. We are policymakers. And so if not us, then who? If not now, then when? This is the moment. It's always been the moment, but particularly now with the chaos and uncertainty and stress, now is the time. Thank you so much.
Well, I have the unenviable position of following both of them, but I agreed to that, so that's okay, here I am. Okay, so I first really just want to congratulate both Nashira and Dr. Ndidi on their unrelenting pursuit of social justice for birthing people. I think you set an incredibly high bar. So I'm here to offer some words around what Mass Health is doing, which is our state Medicaid agency. And I do want to acknowledge, as has already been brought up, the current federal and political climate. And as a Medicaid agency, obviously, we are very aware and sensitive to what's going on. As of now, we are monitoring the actions and statements from the administration, but we have not received any specific directives, as of now, from CMS with respect to the impact of the various executive orders on Mass Health programs or services, including those for birthing people, children, and families. If we receive any of these directives, we will carefully analyze them and communicate them to the providers and members that we serve. But I do want to make it clear that as of now, Mass Health is not pausing or stopping any programs or payments or anything that we currently are doing. I'm very proud that Secretary Kate Walsh and Assistant Secretary Mike Levine have emphasized their commitment to high quality care and access to services for Medicaid enrollees in the Commonwealth. There is a lot of good work happening at Mass Health in general, and especially within maternal health, and I'm really proud to work with an incredible team who show up every day devoted to serving this uniquely vulnerable population. And I do want to say that that team itself is actually pretty new. We just created a dedicated maternal health team a couple of years ago, and to me that is a really powerful statement about the agency's commitment to maternal health and prioritizing it. One of the most important things that we have been able to do, and the initiative I'm very proud of, is our doula benefit, which was launched in December of 2023. And I'm really happy to report that as of now, there are over 200 doulas enrolled as Mass Health providers, and we have served over 1,700 unique Mass Health members. We did ask some of the doula providers to share a little bit of their information, and so I can report that as of March, about 43% of our enrolled doulas responded, and what we found was 1/3 of them self-identify as Black or African American, about 18% self-identify as Hispanic or Latinx, 41% speak at least one language other than English, and in total, our doula providers speak 18 different languages. And the best part is that we have doulas available across every region of Massachusetts. This was really important to us. When we created this benefit, we put a lot of thought and a lot of community engagement into truly making it a community-based doula benefit. And we wanted our doulas to represent the communities they serve so that our members actually feel like they're getting the support they need. And it's not perfect. We have a lot of work to do, but I'm really proud that at least from the start, I feel like we're getting close to that. Dr. Ndidi and Nashira both mentioned the maternal health bill that was signed by Governor Healy in August. We were very excited to support that as well. And there's a lot in there that is directed at insurance companies and at payers, including Mass Health. And so I can share a little bit about what we have done. Some of this has been completed, some of it is still in the works. As of January of this year, we now have pay parity for certified nurse midwives. So we're trying this year, we're trying. It's not, we still have a lot of work to do, but we're trying. So what that means is prior to January, which is a little bit mind-blowing to me, as an OB/GYN who has been trained by and learned from midwives, that midwives in the state were only getting paid 85% of the rate of physicians for doing literally the same thing. So that has been fixed. Yes, thank you. Seems like a easy thing to do, so I'm glad we did it. We expanded doula coverage to adoptive parents of infants under the age of 1. We are going to be covering certified professional midwives, as Nashira mentioned. That is dependent on DPH putting their licensure forth, but once they've done that, we're prepared and ready to cover them, prepared and ready to cover home births. We are really interested also in that 12-month postpartum period. I think we've talked a lot about maternal mortality. I also, with Dr. Ndidi, I sit on the Maternal Mortality Review Committee, and we see there so many of these deaths happen postpartum. And so we're very interested in that. We're interested in the drivers of that, one of them being mental health. And so we do now have a requirement at Mass Health that primary care providers, pediatricians, OB/GYNs, and midwives screen for postpartum depression throughout that 12-month period. Often the screening tends to stop or kind of fade away, but we wanted the providers to feel empowered to continue to screen, even if they might not think that this person is technically postpartum anymore. As any mother in this room knows, postpartum never ends. My oldest child is 7 and I am still postpartum. And we wanted to give guidance about what to do when screens are positive, because as many of us know, sometimes people don't want to do the screening because they don't know what to do if it's positive. So we wanted them to know there are resources, here's what you can do. We're also going to be covering donor breast milk, hopefully, for certain high-risk infants who are hospitalized. Again, this is dependent on some DPH action, but we will follow with that. And then we are going to be covering universal postpartum home visiting as well. So yeah, lots of good work. So we have a really good team. My colleague, Maddie, is back there. She's been a key leader in all of this as well. So thank you for uplifting as others have said, the positive things. I think it's really important to think about that and to know that good work is happening. And on that note, I do want to share, it's worth calling out Mass Health's mission statement, which I do try to look up every now and then and remind myself. The mission statement is, to improve the health outcomes of its members and their families by providing access to integrated healthcare services that sustainably and equitably promote health, well-being, independence, and quality of life. And so many of these concepts have already been discussed and brought up by the work being done. Access, integration, sustainability, equity, health, well-being, independence, quality of life. So while much is uncertain, and certainly at Medicaid we're daily just holding our breaths, but I am optimistic that we do have collective power and we have so many resources and leadership and brilliance in this room and beyond. And I do think we can keep working towards achieving justice for pregnant and postpartum people in Massachusetts. So thank you.
Amazing, all of you. Thank you, thank you. So by design, we did focus all 3 presentations and speakers on this great state of Massachusetts and city of Boston because we are, in fact, a model and because we live here. And the second panel, economic justice, part by design, but really serendipitously, also have been doing their research and a lot of activism nationally, yes, but also have special projects going in Massachusetts. This is a time for us to focus on how we model forward-looking, equity-focused social policy and health policy. So we look forward to hearing from 3 speakers. First will be Sharita Gruberg, Vice President for Economic Justice at the National Partnership for Women and Children in DC. She leads the organization's work pushing for policies that advance an inclusive economy by centering the needs of women of color to promote broad economic growth and an economy that works for everybody. She was vice president of the LGBTQIA Research Communications Project at the Center for American Progress. She received her JD from the Georgetown University Law Center and also a certificate from the Institute of the Study of International Migration in Refugee and Humanitarian Emergencies. Sharita holds a BA in Political Science and Women's Studies from University of North Carolina, Chapel Hill, and was recognized by the LGBT Bar Association as one of the 40 best LGBTQ plus attorneys under the age of 40 in 2019. Nice. Then we're going to hear from Jeffrey Liebman. Dr. Liebman is the Robert W. Scribner Professor of Public Policy at the Harvard Kennedy School, where he teaches courses in social policy, public sector economics, government innovation, and American economic policy. He studies tax and budget policy, social insurance, poverty, and income inequality. For the past 10 years, his work at the Harvard Kennedy School Government Performance Lab has been providing pro bono technical assistance to state and local governments. During the first 2 years of the Obama administration, Dr. Liebman served at OMB, back in the good old days. First as Executive Associate Director and Chief Economist, and then as Acting Deputy Director. And he served also under Clinton as Special Assistant to the President for Economic Policy. And finally, we'll hear from Jessica Ridge. Jess is a BU School of Public Health alum, and since 2014 has led fundraising and systems change initiatives all over the Northeast for Up Together. Up Together is a national nonprofit that works to change the way the U.S. addresses poverty. Since 2020, she has overseen the launch of 20 direct cash, otherwise known as guaranteed basic income initiatives. She specializes in building deep, lasting partnerships that ensure that those with lived experience are at the table. And before joining Up Together, Jess spent 8 years in Boston City Hall with then Boston City Councilor at Large and now Congresswoman Ayanna Pressley. First as her policy director and then as her chief of staff. So whether in the halls of government, philanthropic foundations, or in her community, Jess, listen to this one. Jess aims to slow down and encourage herself and those around her to ideate, explore, and play from a place of embodied connection. She lives in Western Mass with her partner Bruce and her 5-year-old Benyama, where playing in the mud is part of their regular routine. I think excellent practice for us right now, right? So, thank you. We're focused now on family economic justice. Sharita, I turn it to you. I want to note we are running behind, which is kind of normal for these sorts of events. It's possible we'll have to cut short questions at the end from the audience, but we will have time for a bit of a conversation. Thank you.
Thank you. Hi, everybody. As you heard, I'm a lawyer, sorry. But not an amazing OBGYN. I've been blown away by everybody who's spoken before me. Thank you so much for having me. It's really great to be in Massachusetts and Boston right now. I'm from DC, where 10,000 folks who work for the Department of Health and Human Services were fired today, including many working in maternal and child health and research. So truly terrifying times. Also terrifying times. Last week we observed Equal Pay Day, which is the day where we recognize that women are typically paid just 75 cents for every dollar made by a white non-Hispanic man. The wage gap's more than numbers. I'm sure you've heard in the past how long it takes women to catch up to men. The truth is you don't. You don't ever catch up with the wage gap. Those lost wages make the strain women are facing supporting ourselves and our families even harder at a time when rents and the price of necessities continue to rise. The wage gap makes it harder for women of color in particular to cover our daily expenses. Good luck saving for your futures. Once again, might lose Social Security and Medicaid, so good luck to everybody. The money women lose adds up. Without the wage gap, on average, a Black woman worker would have enough money for almost 2 years of childcare, 16 months of rent, or more than 27 months of groceries. To make matters worse, in 2023, the wage gap widened for the first time in 20 years. It was not one policy that did this. It was our policymakers' absolute failure to address any of the systemic barriers that women face to economic security in this country. We need strong anti-discrimination protections. We need them enforced. But anti-discrimination protections alone are not going to close the wage gap. The US, compared to Canada, compared to Germany, compared to any of our peer countries, lags far, far behind in women's economic participation. This is at a cost of $775 billion in losses to annual GDP of the US. And the reason's pretty simple. We are the only wealthy country in the world that doesn't offer paid family medical leave. We do not have paid sick leave. We do not have any kind of supported childcare. And we don't offer supported home and community-based services for our elders. If you're not already, a whole lot of people are about to be caring for kids and their parents. With zero support, oh my gosh, and they just closed down the Administration for Community Living, which is the government agency that supported care of older Americans. So getting harder and harder by the minute. Poverty, though, is a policy choice. We saw that so clearly around the child tax credit expansion. Congress expanded it, cut child poverty in half. The minute they let the expansion lapse, child poverty doubled again. It cannot be clearer that these are solvable problems. We have the tools, we have the support, we just need the will from our leaders. So I'm going to talk in particular about my favorite policy intervention, paid family medical leave. Over 30 years ago, we enacted the Family Medical Leave Act. This provided unpaid, job-protected leave for up to 12 weeks for if you're giving birth, if you're welcoming a new adopted child, if you are caring for your own medical emergency or a loved one's. It was not supposed to permanently be unpaid. We've been fighting for over 30 years to finish this job. But it's been really effective. It's been used over 500 million times. So folks can be there with their kids, with their loved ones when they're most needed, and not have to worry about losing your job to step away. That said, 44% of American workers aren't even eligible for unpaid job-protected leave. And when you're talking workers of color who are more likely to be working in part-time, low-wage job that aren't covered by FMLA, you're seeing even lower rates of coverage. At the National Partnership, we estimate over 2.7 million workers last year needed to take leave but didn't take it, and that was for fear of losing their job, so people who didn't have FMLA. Another 7.3 million had FMLA but couldn't afford to take unpaid leave, because who here can afford to take 3 months off without pay of work? Nobody, not possible. In the 27 states that don't have their own state-paid family medical leave program, women are losing an estimated $19 billion each year from unpaid or underpaid leaves. And so what do we know about the impact of paid leave? I'm gonna tell the story of two Lou's. One is my buddy Lou, who's a nurse in Michigan, a state that does not have paid family medical leave. The other is my friend's new baby Lou in DC, a state that not only has paid family medical leave, but also is, us in New York are the only ones with paid prenatal leave as well. Both my friend Lou and baby Lou's mom had preeclampsia during their pregnancies. My friend, the nurse in Michigan, no paid leave through her employer, was working up until she went into labor with preeclampsia because she could not afford to take a day off, because if she wasn't working, she wasn't getting paid, and every cent she was getting paid, she had to squirrel away, so she could save up for 2 whole weeks to be home with her newborn. 2 whole weeks is all she got. Again, somebody with preeclampsia, gave birth.
we were terrified that we were gonna lose Lou. Now, in DC, a much happier story. Baby Lou's mama also had preeclampsia, but was in a city with prenatal paid leave and paid family medical leave. She was able to get the bed rest that she needed to make sure she had the best birth outcome she could have. She was able to take the time that she needed to be home with her baby. When she went back to work, her husband was able to stay home with their baby and pick up and also get that so important bonding time, which we know from the evidence improves gender equity as well. So I just wanted to share this as an example of how one policy can make such a difference in multiple people's and multiple generations' lives and well-being. Paid leave improves maternal and infant health. It lowers the chances of reporting interpersonal violence, lowers rates of infant mortality, reduces incidence of head trauma caused by abuse among children under 2, because lower levels of stress and abuse also lead to lower levels of abusive behavior, reductions in low birth weight, reductions in preterm births, and all of this is particularly true for mothers of color, especially Black mothers. When you compare the moms who could take paid leave, like baby Lou's mom, with the moms who couldn't, like adult Lou, the chance of being rehospitalized is 50% higher for those who don't have paid leave compared to those who do. Also the same for likelihood of your baby to be rehospitalized in the first year. We just heard how important it is to make sure we're keeping moms and babies out of the hospital during those significant times. Paid leave does that. My team took a look at Massachusetts program and had the most exciting findings. So the very smart economist on my team made a model to compare Massachusetts with similar situated states, and controlling for everything else found that the existence of Massachusetts paid leave program, not even who took it versus who didn't, just having it there, led to 1 fewer poor health day a month for people with depression. Now that doesn't sound that big, but think about what that translates to. That is $1.2 billion in productivity gains annually from reduced absenteeism in the state of Massachusetts, just depression. Also, it's a really great deal. Employers pay $258 per year into the program per employee. The productivity benefit is $880 per year. And when we're talking depression, we're talking postpartum depression. We are talking about how this is a program that improves both the physical health outcomes and the mental health outcomes for new moms, for babies, for families, improves the economy. It is a win-win across the board. Where are we now? Well, we were 2 votes away from a national paid family medical leave program. Didn't get that. But states, as I said, have picked it up. 14 states, including DC, have paid leave. We are also seeing momentum in places we never thought we would. Nebraska, Missouri, and Alaska, all red states, passed paid sick leave on the ballot. Parental leave was just enacted for state workers in Mississippi and Alabama. As states provide paid leave, we're getting more and more evidence of how significant a policy this is, and it's helping us put even more pressure on our electeds to enact this across the country. Urge Massachusetts to continue being a leader, and also shout from the rooftops of what you're doing here. Make your neighbor states jealous, because that's how we're gonna win and spread it across the country.
Thank you for inviting me to be part of this event, and congratulations on the 30th anniversary of your Center for Excellence. I've been struck by all the speakers so far, their power at being able to describe reality and still inspire. I'm not even a lawyer, I'm an economist, so my powers to describe reality may not be so good, but I will still try to inspire. And the way I'm going to do it is by trying to convince you that there is no reason why we can't provide high-quality early education and care to every child. And I'm going to show you how easy it is to do this. And I'm going to also try to persuade you that there's no reason to sit around and wait for Washington to do this. Any state can do this. I would love it to be Massachusetts, just like we were first with the Affordable Care Act, but if our leadership doesn't get around to it, happy if some other state got around to it too, because we need a model that just like we had here under Romney Care for healthcare reform. So the origins of the research I'm going to tell you about is a phone call I received from Amy Kershaw, who's the Commissioner of Early Education and Care in Massachusetts. And I've been friends with Amy for a long time. And in fact, I can tell you exactly how long, because our children were in a toddler classroom together. And the children in question, our oldest children, are now 24. And so I can tell you I've known her for exactly 22 and a half years. And so anyway, Amy called me with an interesting question. Massachusetts was putting a lot more resources into early education, and she was thinking about how do you deploy those resources in a way that's actually heading toward whatever our ultimate vision is of a system of care that's available and affordable and high quality for all. And so I lead a center at Harvard called the Rappaport Institute for Greater Boston that tries to do matchmaking between local policymakers who have interesting questions and scholars who can solve those. And so usually when I get a question like this, I find someone else to answer it. But I immediately knew I wanted to work on this myself, in part because I had just been teaching that week, my week in my American economic policy class about economic disparities. And I'd seen early education show up so many times in the course of my teaching there. Early education is a key part of what one needs to do if we're going to give every child an equals opportunity to prosper, if we're going to close achievement gaps. And it's also, as the most recent speaker highlighted, it's a key part to how we close gender gaps in earnings. My wonderful colleague, Claudine Golden, who got the Nobel Prize in Economics for her telling the story of economic progress for women, she has written recently that if we're going to close that last step in the gap in earnings between men and women, we have to solve the problem that jobs that expect people to be available at any moment of the time to fly anywhere in the world pay a lot more than jobs with dependable hours. And because women end up with caregiving responsibilities, jobs that demand flexibility about when you work and that pay more are often not available to women. And better childcare is part of the way that one could overcome that problem. So one of the reasons I decided to work on this was it seemed like it was the answer to several of the other things I was thinking about, but also I could just see so many parallels between what one needs to do to solve this problem and what we did when I was working in the Obama administration on the Affordable Care Act. I'm not going to go through all the parallels, but I think you'll start to see them as I talk through what the solution is in the early education space. So as I started to do this research, I identified one thing that was a puzzle and one thing that wasn't at all a puzzle. The thing that immediately strikes you if you start working in this area that's a puzzle is that given all we know about how important those early years are and what the returns are to investments in the early years, why in the world is it that we spend about $3,000 per child in terms of public sector spending when they're 0 to 4, and then $20,000 a child once they get to be in kindergarten? I mean, it's just sort of a pretty stunning puzzle. The second thing that struck me immediately as I was starting to think about this is the thing that I said was not a puzzle. Oh, is this a clicker? All right. The thing that's not a puzzle is that the market will not solve this by itself. There's no reason to think that the market left to its own devices is going to give us enough early education and care or high enough quality for the slots that we get. And it's really the same reasons why why the government gets involved in healthcare or gets involved in K-12 education or even in providing Pell Grants for higher education. One issue is this is something we want everyone to have high quality access to, and there are a lot of people who just don't have high enough incomes to afford it. Just to give you an example, the median wage for an early educator, a lead teacher in Massachusetts, is about $22 an hour. So that's about $44,000 a year. There's no way an early educator in Massachusetts could pay for early education for their child. I mean, not even close. I mean, it's about at least $20,000 a year for early education. And if your income's 40, 50, 60,000, how in the world are you going to pay for that? So if we want every child to have opportunity, clearly the government's going to have to step in and pay for it at the bottom, just like we do in healthcare, just like we do in giving everyone K-12 education. The second reason, there's no reason to think that the market's going to get this right, is a slightly more technical argument that something we call in economics liquidity constraints, which basically means if you go to the bank, and suppose you're a 1-year-old, and you manage to crawl your way over to the bank, and you say to the bank, here's the deal, I'm going to make a lot more money later if you give me a loan to pay for my own early education, and I'll pay you back out of that. Well, the bank won't give you that loan. Okay, and because they don't know for sure, and anyway, plus the crawling over their part is hard also. Anyway, so it's the same reason why government steps in other situations. And by the way, it applies to the parents as well. The parents of young children are often, early in their careers, they're going to have, later when they're 50 or 60, they're going to wish they could have spent more money on their children's early education, but they don't have the money at that moment. And so that's the reason to have government get involved and make sure everyone gets high quality care. Third thing that I discovered as I started playing around in this area is that you really got to worry about quality before you worry about just adding lots of slots. And there's some very actually disturbing research of what happens if you just go and try to make as many slots as possible without worrying about quality. So if you look at what happened when Quebec expanded very quickly the number of slots, there's pretty good research showing that it led to bad child outcomes. There's similar evidence from Tennessee, where again, they worked really hard at making as many slots available as possible without worrying about the quality. And so I think it's quite clear you have to start with quality, because the last thing you want to do is actually hurt children by putting them in centers that are not good for child development. So the question is, how do you do that? Well, there are a bunch of things you need to do about quality, but the main thing is pretty obvious. We need to raise the wages of early educators. And there are a bunch of different concepts. I mean, I heard earlier a few minutes ago about the parity for midwives. There are a bunch of different ways you can think about between parity for early educators and K-12 teachers. You can think about having the same annual salary, even though the early educators work 12 months a year and the teachers work 10 months a year. You can think about having the same hourly salary. But just getting to the first of those would require about $6 or $7 an hour more for every early educator in a typical state than we're paying them right now. And the question is, how would you provide that? And actually, we now have some very good examples of how you can do this. Because what you don't want to do is have the government step in, give the center money, have the center take that in profit and not raise the wages of the early educators. So how do you do this? Well, Washington, D.C., Illinois, and every province in Canada have all figured this out. And what you do is you have the government pay for the additional wages. So let's suppose we're going to raise everybody's wages by $7 an hour. The government basically pays $7 pays for that increase in the salary, and then you have a floor on the wages. You have to say, in order to receive this money, if you're a center, you have to pay at least, let's say, $29 an hour, or whatever the floor is going to be, and that makes sure they can't just cut the wages and pocket the money. Okay, I'm already getting a sign saying I need to wrap up, and so I'm going to just quickly say the second thing you got to do is, in every state, there are subsidies for low-income people to access early education, but they're not entitlements like other parts of our safety net, and so there are huge waiting lists. You need to increase the subsidies, but you have to do that after you bring the additional slots online, because it doesn't do any good to have more people able to pay for childcare if there aren't more slots. Then you just get waiting lists and frustration. And so you have to do the wages first, then additional slots second, and then making it affordable. And you have to do it in that. You have to time it right so that as the new slots come on board, that's when you make the subsidies available. Okay, last thing I want to say is, as I was doing this research, I was trying to figure out how many slots we need in a state like Massachusetts. Right now, 52% of young children are in a formal child care setting. Should we be shooting for 60%, 70%, 80%? How do we know? I mean, maybe many people don't want to be in formal care. So I tried to find someone who'd answer this question, and no one had seemed to answer it. So I commissioned a survey of 1,000 mothers in Massachusetts of children between 0 and 4. And I asked if childcare were free, would you use more formal care? More for the people who are already using it. Of the people already using formal care, 71% said they'd use more. Okay, these are people who are on average using about 25 hours. They want 10 more hours on average. The ones who are not currently using formal childcare, 80% of them want it. So it's not that like the people, people have different preferences, they want to raise their children in different ways. The overwhelming majority of people want their kid in a high quality childcare center. And there is no, given how slow it will take us to add more slots, there's no risk of us overshooting. We can go as fast as we can to add new slots, and we will not have too many slots. Okay, I think I will stop there and wait for the panel, and can maybe get an opportunity to explain to you why I think states can solve this on their own, and we don't have to wait for the federal government, but I'm getting lots of waves there that say I should stop. All right, you'll ask later. All right.
Good afternoon. I'm Jess Ridge, and I have the privilege of going last. So I'm really happy to be with all of you and those who are listening in from Zoom. Let's start by taking a deep breath together. Notice your body in the chair, your feet on the ground. And let all the powerful information that you've just received settle in to your spirit, to your being. And trust that you will retain whatever is most essential for you. You don't have to try to hold on to every bit. And in these times, I think it's ever more important that we commit to imagining what is possible. And so for now, I want you to consider, what would it mean if everyone in this country had more than enough at all times and was living a life that they love? What would it do for the individual, for their family, for their community? How would it change this country? So just let that settle in. You don't have to hold on to that either, but maybe just let it be there loosely in your heart as you listen. Up Together is a national nonprofit. We've been around since 2001, and we work to reform the systems that have kept people in poverty. Since 2020, we've implemented more than 50 guaranteed income pilots and invested $210 million in more than 200,000 households across the country. Everything we do is based on our strengths-based approach. We understand that social connections are essential to our success. We recognize that sufficient capital is needed to realize our dreams, and choice, that every person is an expert in their own life, that every person should get to choose how they spend their time, their money, and whether or not and what kind of help they want. Before we go any further, let's level set on some direct cash terms. There's existing cash transfer policies that you may be aware of. Many of them provide an impact for families that is important, but also carry what we would call deficit-based restrictions on what people have to do to use the money or who gets it. I'll lift up emergency rental assistance, which is critical to keeping people in their homes, but sends this message about who is valuable and who we trust. We trust landlords, but not tenants. Universal basic income, which is definitely worthy of discussion another time because the cash payments are unrestricted. You can use them however you want. But the distinction is that UBI provides generally the same amount to everyone in a particular community. The Alaska Permanent Fund is an example of that. Today I'm going to talk about guaranteed income, which is unrestricted cash transfers over a period of time, often monthly. Cash can be used however you want, but it focuses on those living in financial hardship and usually some other factor in addition to that. Pregnant and parenting guaranteed incomes are really popping up, housing instability, or zip code to really how do we focus direct cash on communities of color that have been disinvested in over decades. But why should we talk about guaranteed income? one of the reasons that Up Together talks about it is because despite ongoing increased investments in our means-tested federal safety net programs, as everyone in this room I think knows, our federal poverty rate hasn't really changed since the 70s. And these programs, while they do provide support, often have restrictions that are very harmful to people, and they're also very costly to implement because of that. And the idea of guaranteed income isn't new. It was likely Johnny Tillman, a mom of 6 and welfare rights activist, that planted the idea in Dr. King's ear. So Dr. King and Malcolm X talked about different forms of guaranteed income. She was advocating for a guaranteed adequate income, particularly thinking about mamas like her who were home raising our future without adequate means to pay the bills and provide childcare activities. In 1972, she said, "The truth is a job doesn't necessarily mean an adequate income." And that feels, to Jeff's point, that as relevant today as it was then. So what does the research say about guaranteed income? Well, first, I want to talk about what it means to a mom, a family who received a 24-month guaranteed income in Boston. For the first time, she was able to catch up on her bills and establish an emergency fund, and she said, "Maybe the most meaningful part of this is that I no longer need to work 2 jobs and am able to be home with my kids more. What if everyone lived a life that they love?" Okay, so now the research. In 2024, it was a landmark year, 9 RCTs, 10,000 participants. The data came out. Guaranteed income really took off in COVID because of a lot of federal funding. And so the findings from these studies show what Up Together has found in the more than a dozen studies that we've done. By and large, people are using the money for basic needs, paying their bills, putting food on the table, housing, but it also creates this opportunity to save money for the first time, and in many cases to pay down debt. It often stabilizes or improves housing, and it allows some spaciousness for long-term planning that wasn't available before. Oh, I could go back to school now. I can do this job training program. And it creates more time to spend with family and community. And the media headlines, some of them reported mixed results. And there's some misconceptions that I think are really about this pull yourself up by your bootstraps, mixed with lots of racist beliefs that we've all been indoctrinated with in this country. For today, I'm going to focus on the misconception that guaranteed income is ineffective because it leads to a decline in work. First, if you look at the data here, I don't know who considers 2.8 hours less a week less work a decline in work, but that is how it's interpreted by some. But also, the work data was skewed by 2 subgroups: single moms, and the qualitative interviews suggested that that extra time was used to spend with their children. Blasphemy. And for those under 30, it was because they were using the guaranteed income to pursue higher education. So isn't that a good use of time? And then finally, participants were 5.5 percentage points more likely than the control group to hold off on taking a job until they found one that was interesting or meaningful. Again, what if everyone could live a life that they love? But there are mixed results. Do the findings show that guaranteed income is a silver bullet, that everyone has the same results, that they last beyond the pilot, or have some broad sweeping change in a community? No, they don't show that. But it's really important for all of us to understand, and I think this room gets it, that there is no silver bullet to ending poverty or to ending racism, and both of those are deeply intertwined in this country. From my perspective and Up Together's perspective, the evidence is quite clear. In the absence of enough decent paying jobs and the ever increasing costs of goods and inflation, guaranteed income is an essential support. And I think maybe more importantly, it's pointing us to what is possible when we trust people. In the words of Lida from the Cambridge Rise Guaranteed Income Initiative, people in poverty don't choose to be there. We should all have the right to live a healthy, normal life in this country. And there are options. Sharita talked about one, family medical leave. I'm going to talk about some other. What if all of our safety net programs were run with a strength-based approach? What if they trusted the people who they were intended to benefit? What if we got rid of the cliff effect, which are restrictions in our safety net systems that often force people to decide between taking a promotion or a raise and keeping their childcare, their housing? As Sharita also pointed out, COVID showed what's possible when we expand the child tax credit. It's very clear, the evidence is there. The guaranteed income movement shows us how we can move beyond the framework of supporting the needy to investing in people so that they can create a life of sustenance for themselves. So I invite us all again to consider, what if we believe and our policies reflect that everyone deserves to have more than enough at all times and to live a life that they love? What if future studies on guaranteed income or any of the other policies that we talked about today, what if this was the framework for how they were constructed? And what if this was the framework with which we analyze the data? That's my wish. Thank you all so much.
Everyone, wow. Wow. We have 15 minutes, folks. It's not enough, but we'll take it, right?
Yeah.
We'll take it because you all are here with us, and you have presented us with a lot in both worlds, I would say. It strikes me. I loved the quote you brought. E.B. White, was it? Nashira, we live every day, 1 foot in reality, and 1 foot wanting to change that reality, wanting to change the world. So just very quickly, the birth justice panel, it seems to me you really showed us, again, the Massachusetts example of how local activism, yes, you hit barriers, yes, you do, and yes, it takes 10 years, Nashira, but how local action, fundraising, is getting a job done. And both you, Viveka, and Dee Dee talked to us about the Massachusetts state example in making things happen legislatively, and then Viveka, you are taking it a step further and operationalizing it. Little by little, right? We know in Massachusetts, we hope we can keep doing that to forward maternal health equity. The next panel, you were all so aspirational on one hand, rooting us in data of what's possible. I'm so struck by the pioneering innovations that have happened just in the last, it seems to me, 5-8 years, the evidence that is emerging. Other countries have known it for a long time. FMLA, early childhood education, basic income, and similar social policies. But we're nowhere near there in terms of national progress, even before the current administration. So I have 2 questions I want to start with. And the first one is, picking up where you left off, Jeff. Given what's happening right now, given the aspirations, what we know, we have the knowledge, we have the social strategies, what we don't have is we haven't had the political will, but now we have. Okay, what can states, not just Massachusetts, take us out to some of your other examples that you know about, Jess, Jeff, Sharita, you work nationally. What can states do without federal government support? Jeff, you led us off with this, so why don't you start us?
I mean, the way I look at it is it's likely that there are going to be big federal tax cuts. Why don't we reverse those at the state level and then solve whatever problem we want to solve? The early education challenge that I talked about, to get Massachusetts to a world where every child had a high quality, affordable early education, It would cost a lot of money, but it's not that much money. It's about $1.5 billion. That's like 4% of the state education budget. It's not that much more than a couple of years of inflation adjustments. And so if we decided to do it, we could do it. And certainly if we wanted to redirect whatever tax cuts we get from Washington over the next few years toward solving one of our problems, we could certainly do that.
Hey.
Not just can, I think it's going to be imperative. You talk about early childhood education. Head Start is under attack next. And so it's both a horrifying problem, but also such an opportunity for the states to step in, to step up. With paid family medical leave, it's necessary. And I think even red states that don't want to, I don't think Alabama sat down and was like, oh man, I really want to have this social safety net program for folks in our state. That's not how Alabama state government functions, but it wasn't tenable for the state as an employer to lose employees to the private sector where they're getting these benefits. They had to compete. We've got paid leave in Minnesota. We've got Michigan, Wisconsin, Illinois are feeling that pressure because they're losing workers to states with better policies. In New England, we've got a whole lot of states with paid leave. And so I think we're gonna see some of these pressures and points on states where they can do better. And the innovations we're seeing are also really exciting. FMLA had a really narrow definition of family. You couldn't use it for a lot of folks that you have caregiving needs for. So the other trend we're seeing in states, which is also really exciting, is inclusive family definitions to make sure that you're able to be there or have care provided for you for what your family actually looks like, not just the nuclear family that we've traditionally thought of. So there are opportunities to take the lead, especially as we've kind of lost that assumption that, oh, Congress will save. I don't know whoever thought Congress would save us, but definitely not now.
Right, yeah, thank you. And Jess, I know you think a lot about the opportunities in this moment, despite how counterintuitive that sounds.
Yeah, what's coming to my mind is that states have driven a lot of our most wonderful federal policy movement over the decades. I think about gay marriage in Massachusetts and the ripple effect that had across the country and then ultimately to President Obama as one example. But I think to Sharita's point that this is creating an opportunity for states to have to focus and address things that maybe they didn't have to before. And I think it's a reminder for each of us to really focus on the opportunities that are there, which is really hard to do. We are really being tested right now about what we have capacity to handle. But by design, they are trying to scare us and immobilize us. And so I think about how do we, at the individual level and within our communities, channel up what is possible despite the chaos that's being spun around us.
Yeah, thank you. I don't know where that leaves, red states. Well, I do know where it leaves them, but although you did, Sharita, give good examples of the economic pressures that lead even states that are red to take action. So that's hopeful. Turning to you all on the birth panel, what do you see now as, even in a state sort of counterintuitively like Massachusetts, what do you see as the greatest challenge in this moment, be it for the federal government, shutdowns, disasters, or for more local reasons? What do you see as your biggest challenge right now to progress in the purpose that you have? Who wants to start? Dee Dee?
Yeah, well, there's a ton of uncertainty, as we all know. I think about my situation. I'm a really recently minted full professor. I represent 2% of Black women that are full professors in the academic space. Even more so than that, there's such a paucity, even before this current administration, a paucity of principal investigators of color that are managing large grants in this area. So when I got my R01 grant, as we know, that's a big deal in academia. It's a 5-year, multi-million-dollar grant. That's like 1% of PIs of color that are getting that funded. That was before. So now you add this current administration, it's like, where are the resources going to come from to do this type of work? And as an academic-based but community-facing center, my goal, I think, as a leader of a center, is to have a lot of liquidity in the resources that I have to put it back into the community. So if you're facing this uphill battle with funding, traditionally NIH was the gold standard where we'd get our funding from. Tons of uncertainty about the funding dollars. Now we have to even more so diversify our portfolio of funding. There's a lot of uncertainty. People's jobs and livelihoods and partnerships are on the line. And frankly, the quality of research we're going to be able to produce as a country, nobody here will be surprised about that. What does that mean for the United States footprint globally? What does that mean domestically? What does that mean for evidence-based results? What does that mean for prioritization for funding? All of those things are very much up in the air. That is a lot of uncertainty. That will absolutely translate to lives lost, preventable complications, missed opportunities, delays in care, and the list goes on. So it's a pretty dire time, and I think those of us that are scrappy, I call myself a scrappy investigator, we've always looked in the couch cushions and underneath the coffee table trying to find funding. This is even more so the time to do that, to be able to maintain the research that we know is going to absolutely save lives and contribute to better outcomes in the community.
Yeah, thanks. How about you, Viveka?
Yeah, is this working? Okay.
Yeah.
I think I would echo a lot of what Dr. Ndidi just said too. I think what I worry about is that, and a little bit of what Jess said too, I worry that the ecosystem is going to really shift just into kind of a maintenance mode, just to hold on to what we have and what we've been able to do, and a lot of the really amazing innovations and advances and progress and things that we're hoping to achieve are going to get sort of tabled. The other concern I have, and again, we sit on the Maternal Mortality Review Committee, but I really worry, especially because a lot of that data is handled through the CDC, it's handled through the federal government. What are the kinds of things that we're going to be able to analyze with that data? How are we going to be able to translate that? In our discussions, we talk about discrimination and bias in these deaths, and that's data that's reported and collected. So I do worry about that too, and just the data being such an important tool, as we saw from almost everyone's presentations today. That's how we know what to work on and where to focus. And so, sorry to be bleak, but those are some real issues that I think about a lot. Yeah.
And that very data on discrimination was specifically rooted out from a CDC PRAMS database.
Exactly.
Before everything else was also rooted out. Nashira.
Same question or different question?
Same question.
I think it was about opportunities, yes?
I've asked both, feel free. What's your biggest challenge? What's the opportunity in this moment for you?
Not to minimize the threats by any means, but I feel like we're always going to be the ones to get ourselves free. And so getting hyper-local, being in community, the fact that, in spite of the zoning board decision, organizers are going to meet in my living room tomorrow, as they have since the beginning of time, to figure out ways through oppression and fascism and racism. And so the threats are real, but the love and our political will, I think, are run really deep. And I think that the fear can take us out. And is founded, and also I don't feel optimistic, but I feel resolve, I guess, if there's a difference between the two. I feel resolve that that in coalition and in community, we will hold each other down. The numbers are on our side.
Thank you. I'm gonna. Our resolve is strong, and again, I just want to reiterate how important it is to be together, in person and on Zoom, to buoy each other up, to to play as Jess recommends. And do I have time to ask them a quick round one more or not? Because the one more is a quick round robin. What are you doing to take care of yourselves in this moment? What's working?
Don't start with me.
Just a phrase, yes.
Spending lots of time with my kids, planning my son's birthday party. It's going to be all the vibes on April 19th. My conference coming up, just immersing myself in every other part of my life, staying off social media, maintaining, self-care, sanity, trying to exercise if I can. Peloton, my name is PhDva 0618. And
Okay.
That's it.
Let's go this way.
Sure. Organizing community dance parties and dancing with my kid and making sure I put my feet on the ground whenever I can, like, but on the actual earth.
Yep. Jeff.
I guess I'd say two things. One is just being grateful that we're all in lines of work where we're actually making a difference every day. Think about all the people who are observing what's going on in the world and don't have a way to affect it every day. It's a much more helpless feeling. And the second thing I will say is I've discovered in the first Trump term that I don't actually have to read the newspaper every day. If I read it twice a week, I can stay up to date enough to do my job, and I don't have to be sad the other 5 days.
I've been taking a lot of strength in talking to my community elders. As a queer woman, there's not a whole lot of elders in my community because of the way the AIDS crisis and the federal government's failure to address it allowed it to decimate us. But the ones that survived have so much great advice on what do you do when you're abandoned? What do you do when your community is being ignored? And so I've really found a lot of strength in those elders and learning from those. And it's a great reminder because I can't think of anything as bleak as seeing an entire generation of your community die around you and go from that to, marriage equality, to PrEP, to just all of the, as we're seeing attacks still and the fight's never over, but it's been a huge source of comfort and strength and a lot of joy in dancing and drinking.
Amen.
I would say for me it's been a lot of meditation, getting outside, finding community, finding people who are doing the same good work and holding each other up, and to your point, Nishira, like reminding ourselves that we are all in this together and we will get through it. Yep.
Yeah.
I'll say hugs, actually more than 20 seconds, so co-regulating with another person. My favorite to co-regulate with are my children, and watching puppies on Instagram with my children. That part, right? It's we need the puppies on Instagram.
Puppies, kids love dance, music, meditation, and staying away from the newspaper. Thank you. I hope you've all taken heart and ideas from this. Thank you for coming. Do you want to? You're closing us down. He's the boss.
I'm not. Hugs, 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 hugs. Good. I love that. Thank you. Thank you for the panelists. Thank you, Professor McCloskey. Thank you, President Gilliam. Come to Talbot. Come talk more. We're going over there now. Thank you.